we're going to move on now to the next presentation. The next presentation is from the Mexican Pediatric Surgical Society. And we have Iván León Ortega, who's talking about initial experience with the use of intraoperative fluorescence with indocyanine green in minimally invasive surgery for thoracic duct ligation in pediatrics. And he's coming from the University of Monterrey, Nuevo León in Mexico.
Hello, I'm Dr. Leon. It's a pleasure for me to have this space and share our research with you all. Chylothorax is the presence of chyle in the pleural space, which may be of either congenital or acquired origin. It is associated with significant respiratory morbidity, thoracic cavity compromise, nutritional deficiencies, and immunosuppression. Surgical options include fluorodesis, thoracic duct ligation using an open approach, thoracoscopic surgery, and the creation of a pleuroperitoneal shunt. Our objective is to share our experience with the use of indocyanine green fluorescence in thoracoscopic thoracic duct ligation for patients with chylothorax. We conduct a retrospective, longitudinal, and descriptive study by reviewing medical records from June 2020 to December 2023. A total of 4 patients were included, all diagnosed with chylothorax refractory to medical treatment and treated with thoracoscopic using indocyanine green. After the anesthetic procedure, 0.5 milligrams per kilogram of ICG is instilled percutaneously into the inguinal lymph nodes under ultrasound guidance. The patient is positioned prone with the lateral edge of the surgical table aligned and an elevation of the right side to achieve an ergonomic setup. A 5 mm port is used for a 30-degree optic inserted through an incision posterior to the tip of the scapula in the 5th intercostal space. A pneumothorax is induced with a pressure of 6 to 8 mm of mercury and a CO2 flow rate of 1 to 2 liters per minute. Under direct visualization, 2 additional working ports are placed. A 5 mm port, 2 to 3 intercostal spaces below the camera port, along the posterior axillary line, and a 3 mm port, 1 to 2 intercostal spaces above the camera port, along the mid-axillary line. Insufflation allows for exposure of the inferior pulmonary ligament, which is divided to provide excellent visualization of the posterior mediastinal structures. The right lung is reflected to enable identification of the esophagus and thoracic aorta. Patch pleuritis is frequently observed, often due to the presence of chyle or a history of chest replacement, necessitating adhesion relays when required. An infrared light filter is applied to facilitate visualization of the duct beneath the pleura. A window is created above the thoracic duct, extending from the diaphragm to approximately 3 vertebral body cephala. Once identified, the duct is isolated and ligated with clips at multiple points along its trajectory. This multiple ligation technique ensures definitive control of any leakage. Finally, a chest tube is placed through the orifice of most caudal 5 mm working port. We observed an improvement in surgical time as the learning curve progressed, with an average duration of 75 minutes, ranging from 65 to 85. The causes of chylothorax were as follows: 2 cases of congenital idiopathic chylothorax, 1 case of pulmonary bronchiectasia, and 1 iatrogenic case related to pleural decortication performed for complicated pneumonia. In our series, chylothorax was observed on the right side in 3 patients and on the left side in just 1 patient. During follow-up, the patients demonstrated both clinical and radiological progress, with no recurrences and minimal, nearly imperceptible scarring. Identification of the thoracic duct in pediatric patients represents a significant challenge due to anatomical variability among individuals, as well as factors such as mediastinitis and pachypleuritis associated with chylothorax. Our experience with intraoperative fluorescence has significantly facilitated the identification and interruption of the thoracic duct, achieving successful ligation in 100% of our cases. Ultrasound-guided installation of ICG directly into the lymph nodes is a safe and effective method for visualizing the thoracic duct. The use of this technology has enabled us to reduce surgical time without complications, resulting in shorter hospital stays. conclusion, our experience suggests that the use of ICG is a safe and effective tool for identifying the thoracic duct during minimal invasive surgery, thereby facilitating its ligation. We aim to achieve even better outcomes as the number of cases increases. Thank you very much for your attention.
Great presentation. That's a great technique for a very sometimes incredibly frustrating problem. I think I understand well, and it looks great for the iatrogenic, but I was surprised that you had cases where it was congenital lesions. And did you find the same thing? Was it ligating the thoracic duct, or did you have to ligate other places and identify other sources using the ICG?
Yeah, thank you. Thank you very much. Excellent question. We only had one patient with congenital, so we did the same technique. We open a window into the pleura and then we saw the portion of the thoracic duct where it's leaking. Then we decided to make apply multiple clips for try to obstruct any branch that might have.
A couple of questions. We have one from the chat, and then first of all, I've tried this for iatrogenic ones, and it was a lot pretty as yours. There was a question about what technology do you need from an imaging standpoint? Do you have a special system or a laparoscope for that? And then there was a question about how long before the operation do you actually give the ICG?
Yeah, I think that is a really good question, and unfortunately, the platform that we might use, I think is one of the most important variables. So we don't have nothing to disclose. So, but we use the system from Stryker with the ICG camera, 5 millimeters laparoscope, and the dose is 0.5 milligrams per kilo. And we apply around 45 minutes prior the position and starting the surgery. It might have been an issue from technical factors because talking with some colleagues, they don't have the same the results.
Yeah. Well, thank you so much. It's a very important presentation. Thank you.
Thank you very much.